Is that genetic work moving along smoothly? Is it something that's available now? Is it something that won't be available for years yet?
It's moving along slowly. You know, I think here we have like such as ovarian cancer where we can't really necessarily image it right away. The CA125 blood marker has been a blood marker that can be a good surrogate for ovarian cancer and has been evaluated in who to screen. You know, the issue with diagnosis and screening becomes more of a public health issue with cost effectiveness on who do we actually screen, and is it really cost effective of which population to screen and finding it early. So that's why you will commonly hear the the controversy of screening for young women with breast cancer or prostate cancer with men. You know, because sometimes the cost effectiveness may not be, depending on how they interpret that and depending on how this is evaluated or studied, you know, one can reach to different conclusions. But I think it's a very fair conclusion to say that early diagnosis and stage and identification of early stage of whatever cancer leads to a much better outcome. The utility and effectiveness of a screening program is a separate question. But I think what we are trying to say is that having identified the cancer early leads to a much better outcome. The key now is to link it with a cost-effective screening program that makes it worthwhile to proceed in trying to diagnose these cancers early. So that's really the key.
Genetic testing is not standard of care.
I mean, for what? For early diagnosis of cancer. You know, I mean, it can be used to characterize tumors and advanced cancers. You know, that's so. Just want to clarify what we mean by that in terms of, you know, standard of care. I mean, and I think right now we can say that we don't use that right now to diagnose early tumors.
Okay, got it. So if a patient wanted to ask for this test and it isn't something that their physician does routinely, what would they ask for?
Yeah, I mean, right now, when they have a cancer, and typically if it's an advanced cancer that has already been undergone treatment and has been resistant to treatments, there are now genetic tests that can help identify newer treatments that are possibly more amenable to it. And so, you know, a company like Foundation One is a perfect example that will be able to run sampling. And you can use, you know, now there's this term called liquid biopsies, you know, where we can, because we need new tissue. And so instead of trying to get an actual histologic specimen, you know, the liquid biopsy from the blood is now providing information to help with these genetic tests. So that's another area of great advancement, because sometimes it's not always easy to get new tissue for these patients.
What do you see as the role in genetic testing in hereditary cancers?
Yeah, I think these patients will be identified much earlier on. I think, you know, with us obtaining, you know, accurate family histories for us to really be attuned to those patients that would be most amenable to these genetic screenings that seem slightly suspicious of a hereditary syndrome. We could be able to identify them early and be proactive about their care, whether it's close surveillance, whether it's, you know, active treatment. I mean, these patients will have a much better outcome because of being much more proactive with their care. But, you know, mind you, I still want to reiterate that the majority of cancers are environmentally induced. I mean, most of the cancers, only 10% of cancers are hereditary. So, I mean, the majority is still 90%. So, I mean, that's, you know, I think that's something that we sometimes need to clarify, because sometimes when we understand that cancer is a genetic disease, but not necessarily inherited all the time. And that's important.